Welcome to the MS-Perspektive podcast. Perspective with a K, as I'm German. I'm Nele Handwerker, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins.
This podcast is supported by Mid-Mission, a project of the nonprofit Hertie Foundation.
Hello and welcome to episode number 32, ECTRIMS 2023, Day 3, Pediatric MS, Female Health, Prodromic MS and HSCT in MS. The third day at MS Milan 2023 offered again lots of interesting topics. This time I selected the following ones. Scientific session number 15, Pediatric MS, updates on diagnosis, prognostic and treatment. Scientific session number 20, Female Health. Hot topic 8, Prodromic MS, can we reduce the risk of MS conversion and progression? And hot topic number 9, HSCT in MS, a long story with new perspectives. Just a remark at the beginning, as for the summaries before, I took most of the data and statements directly from the speakers' presentations without any rewording. But let's start now with scientific session number 15, Pediatric MS, updates on diagnosis, prognostic and treatment. What is the diagnostic workup and prognosis of pediatric MS? By Barbara Kornick. The classical approach is used for children as it is for grown-ups to get a correct diagnosis or differential diagnosis, including clinical tests, an MRI, lumbar puncture to check the cerebrospinal fluid, CSF, serum, which means blood, optical coherence tomography, or for short OCT, serum neurofilament light chains, or for short SNFL. As for adults, the McDonald criteria from 2017 is used as diagnostic criteria for pediatric onset of multiple sclerosis. This includes dissemination in space, so one or more lesions in minimum 2 areas, and these areas can include periventricular, juxta or cortical, infratentorial, and spinal cord. There has to be as well a dissemination in time, which means simultaneous presence of enhancing and non-enhancing lesions, or further T2 or contrast-enhancing lesions on a follow-up scan, presence of CSF-specific oligoclonal bands. It is important to make sure that it is not an aquaporine 4 NMOSD or MOGAD disease, as they are treated differently. It is also very important that all involved parties working together smoothly to guarantee the best possible treatment and outcome of a child or teenager with multiple sclerosis, including the healthcare professional, HSCP, the family, the patient itself, and the society. The prognosis is influenced by the following factors: physical disability caused by the relapse-associated worsening, or for short RAW, RAW, and progression independent of relapse activity, or for short PIRA, PIRA. Cognitive deficits, neuropsychological problems, quality of life, for short QOL, education, and socioeconomic outcomes. What are indicators for a negative prognosis? For relapses and relapse-associated worsening, RAW, it is the recovery from relapse, so incomplete recovery from the first attack, pattern of relapse, spinal cord and brainstem attacks, number of relapses, so frequent attacks during the first years. The just mentioned factors indicate an earlier accumulation of irreversible deficits and an earlier conversion to SPMS, so secondary progressive MS. Even so, the recovery after a relapse is better in children and youngsters due to the earlier start of MS in life, and often a higher MS activity, they tend to convert at a younger age into SPMS. Let's talk about the progression independent of relapse activity, PIRA. The overall clinical disability accumulation is less common in children and youngsters compared to adults, and PIRA contributes to a lower extent to the disability accrual compared to RAW. Cognitive impairment is found in 30 to 50% of pediatric MS patients, including information processing speed, memory, and attention. When they are matched with people with MS onset as adults of the same age, disease duration, sex, and EDSS, the ones with pediatric onsets are more severely affected. MRI controls of brain volume provide additional evidence of this. The percentage of fatigue and psychiatric comorbidities like depression and anxiety is higher as well. And of course, all of this contributes to worse socioeconomic outcomes for later adult life. But the good thing is that the prognosis for pediatric onset of MS is improving more and more since DMTs are in use, especially high-efficacy DMTs. What are the treatments for pediatric MS? By Tanua Chidnis. The overall goal is to support these children and teenagers in having a healthy and fulfilling life despite the pediatric onset of MS. Unlike adults, the majority of pediatric patients acquire disability through relapse and relapse-associated worsening, so RAW. So healthcare professionals need to focus mainly on preventing relapses and new MRI lesions in order to prevent disease progression, PIRA, and the change into SPMS. Furthermore, it is a goal to improve existing neurological symptoms, cognitive outcomes, and quality of life. Shared decision-making plays a crucial role in pediatric MS, and besides the pediatric patient and clinician, the parents or caregivers are involved in this process as well. Choices need to be introduced and options described. HSCPs need to help patients explore their preferences and make decisions. Potential barriers on this path are available expertise, medical literacy, all parties involved in decision-making, availability of DMT options, adverse events, and adherence. Information can be provided by the use of clinical trials, prospective observational studies, and the experience of the clinician. As of October 2023, regulatory administration approval exists for the following disease-modifying therapies. A clear yes in the EU and no in the US for beta-interferon, Copaxone, Aubagio, which is in phase 3 studies, Tecfidera, which is in phase 2. A yes for both the EU and the US for Gilenya, which is in phase 3 studies, and a no for both the EU and the US for Tysabri and Lemtrada. Tysabri is in phase 1 and Lemtrada is halted. There's no decision from regulatory for Ocrevus, which is ongoing, and Kesimpta, which is ongoing. From what is known so far, high-efficacy disease-modifying drugs should be the first choice in pediatric MS, given the highly inflammatory nature of the disease and short and long-term impacts of relapses. The DMTs are working more effectively in pediatric patients, but there are as well more serious adverse events. So it is important to inform the patients and parents or caregivers about potential side effects, but also about the prognosis if the MS is not treated or just treated with platform therapies. Careful monitoring for disease activity and progression independent of disease activity, PIRA, is key. The recommendation is to do another MRI 6 months after starting the DMT. The role of serum, which means blood biomarkers, is not 100% clear yet. Mitigation strategies for adverse events are important. DMT should be started as early as possible, so DMT screening tests should be started right at diagnosis, including antibody screening tests and starting to vaccinate if necessary. Communication with the insurance is important to avoid logistic barriers. Patient and parents need to get educational materials and the option to ask their questions and discuss potential concerns. If there is a need to change the drug, it has to be done rapidly for the ones that might cause rebounds, as the rebounds appear much earlier in younger patients. And maybe shorter intervals are needed for B-cell depleting therapies due to the young bone marrow and earlier return of B cells. A few words on non-DMT management. The patient and family should be offered a psychologist or family counselor. Cognitive testing every 1 to 2 years makes sense, and support from a neuropsychologist. For teenagers, contraceptive use is important. Transitional care happens normally between the ages of 16 to 22, depending on the country. Early preparation of this transition is beneficial. Besides demanding college or work schedules, young adults face challenges with fatigue, cognitive issues, and physical deficits. Continued educational and psychosocial support are helpful to overcome independent care challenges like appointment scheduling, adherence to and renewing medication, and MRI monitoring. More information on optimal symptomatic treatments for pediatric MS is needed, as well as innovation in safe, effective therapies for the earliest form of the disease. Let's move on to Scientific Session 20, Female Health. Lessons learned from RCTs, registries, and real-world experiences for breastfeeding by Kristen Crisco. Let's start with the postpartum MS relapses. The individual risk of mothers depends on the relapses in the year before or during pregnancy, the radiological activity before pregnancy, the disability status, higher disability is associated with a higher risk, and the discontinuation of certain high-efficacy DMTs like natalizumab or fingolimod. Good prevention options for relapses include breastfeeding and DMT resumption. Potential mechanisms for the benefit include hormonal changes. This protection is lost when supplemental feeding begins, but these positive effects of breastfeeding are limited in time and have only a modest benefit. That's why many women would benefit from also resuming or starting a DMT. The safety of DMTs for babies depends on the type of DMT. Injectables are considered safe, and monoclonal antibody therapies as well due to the large molecular size that results in a low transfer to the breast milk. With cladribine, mothers can breastfeed 7 days in Europe or 10 days in North America after last tablet. Breast milk, meanwhile, need to be pumped and thrown away in order to avoid stopping of the breast milk. Let's talk a little bit about the effect of DMT initiation on postpartum relapses. Platform injectables do not reduce the risk of early postpartum relapses. Higher efficacy DMTs like natalizumab may reduce the risk of postpartum relapses at months 3 to 4. Anti-CD20, which means B-cell depleting therapies before and or after pregnancy, result in a well-controlled disease activity. So let's come to the summary. Exclusive breastfeeding should be encouraged. If mothers don't plan to breastfeed, a rapid resumption of DMT within 2 to 4 weeks postpartum is recommended. If mothers plan to breastfeed, platform injectables or monoclonal antibody therapies for higher active MS should be considered starting at 2 weeks postpartum once the breast milk is mature. Or these mothers remain off DMT with rapid weaning and reinitiation of DMT when stopped. There is emerging data on new DMTs for use during lactation. Compatibility with breastfeeding. Glatiramer acetate and interferon beta are compatible with breastfeeding. Yes, if needed, is okay for natalizumab, rituximab, ocrelizumab, and ofatumumab. And there is a clear no for dimethyl fumarate, fingolimod, teriflunomide, and cladribine. So let's come to the conclusion. MS therapy decisions before, during, and after pregnancy are complex and need to be tailored to each individual woman and her level and risk of activity. It is best to talk openly about the options with an MS specialist. The pregnancy itself lowers the activity of the disease, but it is going back sooner or later to the level from before the pregnancy postpartum. Breastfeeding is good for mother and child and should be recommended and supported, and there are lots of options to do so and keep the MS under control. So let's talk about hot topic number 8, prodromic MS. Can we reduce the risk of MS conversion and progression? And I start with a presentation by Helen Tremlett about the prodromic phase. Healthcare use is higher in the 5 years before onset, defined as a first demyelinating event or MS symptom onset. This is based on a study in 4 Canadian provinces with 14,428 MS cases, compared with 72,059 matched healthy controls. Especially the last 2 years before MS onset show increasing healthcare need. The given numbers are for the last year of onset. 78% higher rate of hospitalizations, 88% higher rate of physician service use, 59% relative increase in drug prescription numbers, drug classes dispensed. The complexity of the MS prodrome include a myriad of issues without a single feature specific to MS. Depression and anxiety, psychiatry visits, irritable bowel syndrome, urologist visits, headaches and migraine, sleep disturbances, and dermatologist visits. Similar findings came up to 10 years pre-first MS record for another study done in UK and a third study done in Sweden and Canada, showing even higher rates of physician visits up to 15 years pre-MS onset, with 46,727 MS patients and 194,493 matched healthy controls. Lower cognitive performance up to 2 years before MS symptoms onset versus age-matched controls from Norway. For PPMS, so primary progressive MS, a lower cognitive performance was measurable up to 20 years before symptom onset. What are the implications of this? Cognitive decline is measurable during the MS prodrome. PPMS could start decades before first apparent progressive symptoms. Summary. Neurodegeneration is already present in the prodromal period, up to 6 years pre-MS onset, proven by high serum neurofilament light chains that are measurable. Early recognition could help with secondary disability prevention. That suggests an earlier window of opportunity to identify MS. It could help to alleviate uncertainty, start with DMT use right away, and identify prodromal MS for novel neuroprotective randomized controlled trials. But it is important to balance prompt recognition and diagnosis against over- or misdiagnosis of MS. The second presentation under the topic was about radiologically isolated syndromes by Christine Lebrun-Frenet. Can we prevent MS onset for patients with very clear MRI findings who are fully asymptomatic? After 2 years, 19% will have MS. After 5 years, 35%, and 51% after 10 years. Risk factors for a clinical event include age below 37 years, presence of oligoclonal bands, OCBs, presence of gadolinium-enhancing lesions, presence of infratentorial lesions, and presence of spinal cord lesions. So the risk stratification is important to identify whether early treatment with DMT might be reasonable to prevent or delay MS onset. The risk increases to develop MS within 10 years with the amount of risk factors. 0 to 1 factor means 29% converted. 2 factors means 52% converted. 3 factors means 68% converted. And 4 factors means 87% converted. There is the ARISE study, Earlier Treatment Strategy for Future MS Patients. Earlier treatment for at-risk people may have profound effect on long-term disability progression. In this 96-week study, treatment with dimethyl fumarate resulted in over 80% risk reduction relative to placebo in the prevention of a first clinical event related to CNS demyelination. There is as well the TERRY study. Confirmation was another mode of action. Teriflunomide brought a 63% risk reduction. So the summary of the 2 studies, 2 prospective double-blinded randomized studies in 2009 RIS with 2 DMTs showing that we can have an impact on MS. Conclusion. RIS is very rare as it happens accidentally. MRI expertise is crucial. At 10 years, a majority of people with 2009 risk criteria will develop clinical MS. The risk of MS increases with the number of risk factors. 2 phase 3 studies have demonstrated the benefit of early intervention. And for all other cases, please stay close and see if changes happen that suggest to become active on early treatment. Hot topic number 9. HSCT and MS, a long story with new perspectives. Immunological Rationale for HSCT and MS by Paolo Muraro. Highly targeted treatment strategies are quite selective. The strengths are fewer off-target effects, better tolerability and safety. The weakness? They are less effective or effective only in a subset of patients. Autologous HSCT strategy is non-selective. The strengths? It is more effective in a larger proportion of subjects. The weakness? It has a worse tolerability and higher front-loaded risk. Immune resetting for treatment of autoimmunity. Rationale? Lymphoid ablation allows destruction of mature lymphocytes regardless of their specificity. Homeostatic regeneration of the immune system erases the memory of previous disimmune activation. The expected evidence is, number 1, ablation of old adaptive immunity, including the pathogenic. Number 2, reinstatement of potentiation of immune regulation. Number 3, repopulation with new adaptive immune repertoire. Is this a real immune resetting? Number 1, depletion of inflammatory cells or downregulation of inflammatory molecules. There is evidence of suppression of circulating pro-inflammatory cytokines in MS patients after HSCT. Number 2, improvement of immune regulation. The frequency of regulatory natural killer cells increases post-AHSCT. Changes in natural killer cells inversely correlate with changes in pro-inflammatory Th cells after AHSCT. Number 3, regeneration of the adaptive immune system. Removal of pre-existing blood CD4 and CD8 T cell repertoires after AHSCT. Removal of pre-existing T cell clones following AHSCT for multiple sclerosis. The effect increases over time. Study done where it was checked pre-therapy to months 12, 24 and 48 after AHSCT. So let's come to the conclusion, and I think it was a little bit too much details. The evidence of regeneration of adaptive immunity following HSCT grows. More data is needed on effects on B cells and related molecules. Further studies are required to demonstrate relevance of immune changes to clinical outcomes. RCTs, so randomized controlled trials, of HSCT versus high-efficacy disease-modifying therapies are ongoing or planned and include mechanistic studies. The next presentation in that session was HSCT as an early rescue strategy after DMT's failure by Lars Boe. Open questions. When to switch from a standard treatment? From a low-efficacy treatment? From one previous high-efficacy treatment? From 2 or more previous high-efficacy treatments? There is no general agreement on this. It seems that there is not much time to make this decision, as the early impact on an aggressive MS course is having long-term impacts on disability. It is important to start high-efficacy treatment very early. Proportion of MS patients with NEDA, no evidence of disease activity, at year 2 is rather low, even with high-efficacy treatments that reach up to 50%, while data from older AHSCT studies reach levels of 70 to 90%. A new study from 2023 showed the association of AHSCT with preventing relapses and facilitating recovery from disability was considerably superior to fingolimod and marginally superior to nazalizumab. This study did not find evidence for difference in the effectiveness of AHSCT and ocrelizumab over a shorter available follow-up time. There is a need for randomized trials with newer and high-effective treatments. So let's come to the conclusion. AHSCT should be available for RRMS patients when standard treatment is no longer effective and when treatment options are limited. HSCT is more likely to have a good effect in younger patients with a shorter disease duration with a low disability. There is an increasing use of high-efficacy treatment early in the disease course of RRMS. The subgroup with indication for HSCT as a rescue therapy may grow smaller. Cost-benefit, need for data from long-term follow-up. Demonstrating a higher efficacy may require larger studies, a combined analysis of data from several ongoing studies. The next presentation in that session was HSCT in highly active naive patients, Protocols, Evidence for Efficacy and Safety by Richard Nicholas. AHSCT and RRMS, the story so far. Historically used in late MS with less benefit and more side effects. In UK NHS practice, available if failed a high effective DMT with new disease activity. RRMS trials versus high-efficacy DMTs are ongoing. It can be used in naive RRMS with the STAR-MS study. Naive relapsing remitting MS, the rationale. The choice of younger patients earlier in their course of disease with less disability, along with actively inflammatory disease, has resulted in better outcomes with the AHSCT than had been seen in the earlier studies. Younger and less prior therapies, lower treatment-related mortality over time. Highly active MS, HAMS, aggressive malignant. 4-15% of MS patients have an active disease from onset. The most important features include frequent relapses with incomplete recovery, 2 or more, high radiological burden of disease, new T2 or gadolinium-enhancing lesions, rapid accrual of disability after disease onset, EDSS of 4 at 5 years, despite treatment with 1 or more DMTs. Otherwise typical features of MS. But it is difficult to target those at risk before permanent disability has accrued. AHSCT as a first-line DMT in aggressive MS. 5 European and North American centers retrospectively evaluated. The median interval between diagnosis and AHSCT was 5, varying from 1 to 20 months. 20 patients with a median age of 28 years, varying from 17 to 47, with 50% female. Multiple poor prognostic factors, 8 patients with 2 relapses, 9 patients with 3 to 4 relapses, 3 patients with more than 4 relapses. All 20 patients had incomplete recovery. The median pre-transplant EDSS score was 5.0, varying from 1.5 to 9.5. 3 different treatment regimes were used. The outcomes: the median follow-up were of 30 months, varying from 12 to 118. Median EDSS score improved to 2.0, varying from 0 to 6.5. No patient had further relapses. 3 had residual MRI disease activity 6 months post-transplant, but no further new or enhancing lesions were observed in subsequent scans. Naive RRMS, the decisions. MS is a long disease. Is really highly active treatment better? Induction therapies, do they really work? Are we trading short-lasting efficacy for lifelong cumulative toxicity? Naive RRMS, conclusions to date. Long-term treatment strategies for MS are continuing to evolve. The efficacy and side effect profile of AHSCT is similar to its use in active RRMS despite DMT. Optimal treatment protocols are still being tested. AHSCT is gaining traction as an option for those with ongoing RRMS despite high-efficacy DMT treatment. Multiple RCTs, so randomized controlled trials, are testing whether AHSCT is superior to high-efficacy DMTs. AHSCT has been a possible treatment option in aggressive MS without treatment with benefit if used early on. Use in naive patients who do not have aggressive MS should be within the context of clinical trials. With that, I'm at the end of my summary of MS Milan 2023. I hope the selected topics were interesting for you. There's still lots of open questions and many fields where research needs to find solutions. But with each step of understanding the disease better, it is more likely to find ways to avoid the onset, find better symptomatic therapies, and hopefully ways to reduce disability burden. As mentioned before, I will try to get some of the experts for detailed interviews. By the way, next time I will interview Professor Dr. Patrick Curry about the topic of can neurodegeneration be treated in MS by modulating HERV-W. A very interesting topic, so tune in again and hear you next time. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. Hear you next time.